Hello students, welcome to this session. I am Dr. Rajeshri MUTHA, Department of Microbiology. So now we will see in detail Corynebacterium diphtheria. So morphology of Corynebacteria, they are club-shaped, irregularly stained, gram-positive pleomorphic rods. Usually the arrangement is in V or L form, and it is also called a Chinese letter or cuneiform arrangement. And then it is because of the bacterial division takes place, but these daughter cells, they are not separated and they remain at acute angle, that is V and L shape. It is also called a snapping type of division. These metachromatic granules, they are present at the end of the bacteria, also called as polar or Babes Ernst bodies or volatilin granules. They are present at the ends or poles of the bacilli. They are storage granules and they contain polymetaphosphates. They are strongly gram-positive as compared to the other part of the bacteria. They are stained by Loeffler's methylene blue. They appear as bluish purple metachromatic granules. And special stains for these granules is Albert, Nizar or Ponder stain. And they are properly developed on enriched media like blood agar or Loeffler's serum slope. So inhibition of translation step of protein synthesis, and this is a mechanism of diphtheria toxin. The factors regulating this toxin production are phage coded bacteriophage. It is also called as beta coryneiphage. It carries tox gene. Then iron concentration, it should be 0.1 milligram per liter. If the iron concentration is increased, it is causing negative effect. Then DT repressor gene, that is negative regulator. Biotypes like Graves, Intermedius, Mitis all produce this toxin, and other species are also producing toxin. They are Corynebacterium ulcerans and Corynebacterium pseudotuberculosis. This toxin can be converted toxide, which is used for the vaccination. So what is toxide? Toxide is a form of toxin in that virulence is lost but antigenicity is retained, and this is made by use of formalin, acidic pH or prolonged storage. So this is a mechanism you can see here. Corynephages, controls toxin production. Then here you can see this A part diphtheria toxin is enter after the binding of this B part to the cell membrane, and then it activates elongation factor 2, and it prevents protein synthesis by ribosome and ultimately cell death. The pathogenicity of diphtheria, it is a toxemia, not a bacteremia. That is disease of diphtheria caused by toxin produced by Corynebacterium diphtheria, that is diphtheria toxin. These bacilli are non-invasive. They secrete toxin and then which spreads to the various organs through bloodstream, and this toxin is responsible for all type of manifestations like local, that is respiratory, and systemic complications. In that the pseudomembrane is formed. The toxin causes necrosis of the epithelium and produces exudate, and then causes ulcers. They are lined by the tough leathery greyish white pseudomembrane coat, and in this it is surrounded by neutrophils, RBCs and bacteria. So it is called as pseudomembrane because it is difficult to remove that membrane, and while removing it causes bleeding. So it is called as pseudomembrane. The incubation period of this disease is 3 to 4 days, and different sites are there like fascial. It is a commonest site. It consists of tonsil and pharynx, then laryngeal, nasal, otitic, conjunctival, genital like vulval, vaginal, prepucial and cutaneous. So these are the sites of the disease. Then in clinical manifestations, most common manifestation is fascial, and in that respiratory diphtheria is there. So tonsil and pharynx are involved, and then nose and larynx, the common site. Incubation period is 3 to 4 days. In fascial diphtheria, pseudomembrane is adherent to the mucosal base and it bleeds on removal. It is extending to larynx and bronchial airways, and therefore it causes bronchial obstruction and then may cause asphyxia. There is bull neck appearance. The tonsillar swelling and neck edema causes bull neck appearance of the disease in the patient, and the symptoms are foul breath, thick speech and stridor. So here you can see this white patch, that is pseudomembrane, and in this child you can see this bull snake, that is cervical adenitis. So this is a boy 10-year-old with severe diphtheria. So in that conjunctivitis, pharyngeal membrane is there, and then bull neck, severe myocarditis, and all vaccines contraindicated. Here you can see this white patch, that is pseudomembrane formation and bull snake in this child. The other type of diphtheria is cutaneous diphtheria. It is punched out ulcerative lesions with necrosis due to organism itself and not because of the toxin. It may be caused by non-toxigenic strains. Increasing incidence in especially in vaccinated children, because antitoxin cannot prevent this disease because it is not toxin mediated, it is because of the bacteria. In pathogenicity, according to the clinical severity, the disease is divided into three types: malignant, septic, and hemorrhagic. So in malignant, there is severe toxemia with marked adenitis and death due to circulatory failure. In septic, there may be ulceration, cellulitis, gangrene around the pseudomembrane. Hemorrhagic, bleeding from the edge of the membrane, or sometimes other sites like epistaxis, conjunctival hemorrhage, purpura, and generalized bleeding can be there. So these are the three types: malignant, septic, and hemorrhagic part of the diphtheria. The systemic complications, mostly they are neurological manifestations. They are toxin mediated, non-inflammatory demyelinating disorders of cranial nerve involvement, peripheral nerve involvement, and ciliary paralysis. There can be myocarditis. This typically associated with arrhythmia and dilated cardiomyopathy. The complications of diphtheria are asphyxia because of the mechanical obstruction of the respiratory passage by pseudomembrane. Acute circulatory failure may be peripheral or cardiac origin because of the toxin, and post-diphtheric paralysis may be palatine or ciliary muscles are involved, and there is spontaneous healing can be there in third or fourth week. Septic complications like pneumonia, otitis media can be there. Laboratory diagnosis. So this is a risk of respiratory obstruction can be there. So treatment should be started immediately on clinical suspension without waiting for the laboratory reports. The laboratory diagnosis is necessary only for the confirmation of clinical diagnosis or initiating the control measures and epidemiological purpose. So in lab diagnosis there are two parts. First is the isolation and identification of the bacteria, and second is the toxin demonstration test. So this isolation and identification method, two swabs are collected using a thumb depressor from a pseudomembrane part in a sterile container. And in toxicity testing, they can be in vivo or in vitro testing. So the specimen can be throat swab containing fibrinous exudate and portion of pseudomembrane. So first step after the specimen collection is direct microscopic examination. So it can be done by different staining methods. So first, gram staining. So in that you can see gram-positive bacilli arranged in Chinese letter pattern, that is V or L pattern, and irregular staining with clubbed at the ends of the bacteria. In Albert stain, the bacilli are green in color, and at the end you can see metachromatic granules. They are stained bluish black in color. Neisser stain you can see here. So red color bacteria and metachromatic granules are bluish in color. Then you can do culture inoculation. So the bacteria is fastidious, aerobe, and facultative anaerobic bacteria. So the first method can be enriched media. So it can be blood agar or chocolate agar. On that you can see small circular white color colonies. The second media is Loeffler serum slope. So nutrient broth with horse or serum is added in that and glucose. So colonies may be seen 6 to 8 hours. It is a base medium for the metachromatic granules production. Disadvantage: if it incubated more than 6 to 8 hours, then there can be growth of throat commensals. So next is a selective medium. So that is blood potassium tellurite agar. So in that you can see black color colonies because potassium tellurite acts as a inhibiting agent. So only Corynebacteria diphtheria is selectively grown. So this potassium tellurite is reduced to metallic tellurium, and that is black in color, and so the color of the colonies is black in color. In biochemical reactions for the identification of Corynebacterium diphtheria, it is catalase positive, but oxidase negative. And on his serum, sugar media used for the testing sugar fermentation. So diphtheria bacillia ferment glucose and maltose, all types, and starch is fermented by Graves type only with production of acid and no gas. Urease test is negative in Corynebacterium diphtheria, but it is positive in C. ulcerans and C. pseudotuberculosis. Now next step is toxin demonstration. So it can be uh, in vivo or in vitro test. So in vivo by use of animal, that is guinea pig. So it is of two types, subcutaneous inoculation or intracutaneous inoculation. So in subcutaneous inoculation it leads to death of the test animal within 4 days. So this method is not used. The second method is intracutaneous inoculation. There is necrosis at the site of the injection and within 48 to 72 hours, and there is no death of animal, and many tests can be tested at the same time in the same animal. This is the advantage of this. In vitro test, the best method is Ilex gel precipitation test or detection of tox gene by PCR method, or detection of toxin by ELISA or immunochromatographic method, or tissue culture method. So these are different in vitro test. So in vivo test by use of animal. So in that, the test animal is given injection 5 ml of diphtheria, C. diphtheria cell suspension. Control animal is given injection 1000 units of Corynebacteria diphtheria antitoxin and 5 ml of C. diphtheria cell suspension. So the animal is dead and control is alive. So that is toxigenic strain of the C. diphtheria. Test alive and control alive, that is non-toxigenic strain of the organism. Test dead and control dead, so that it may be because of the toxicity not due to C. diphtheria, some other reason is there. In vitro test toxin demonstration, so that is Ilex gel precipitation test. So it is immunodiffusion in gel method. So in that, petri dish with 20% horse serum agar is taken, and on that filter paper soaked with diphtheria antitoxin is applied in the center, and then streaks are done right angle to the disc, that is test strain, the toxigenic strain and non-toxigenic strain. So non-toxigenic strain will not show precipitation, toxigenic strain will show line of precipitation. Where the toxin and antitoxin meet, there is formation of precipitation band. The incidents are decreasing widespread use of the vaccination coverage. The source of infection is carriers 95% and 5% from the cases. The carriers, they are temporary, the persist for a month, and chronic persist for for a year. The nasal carriers are more dangerous because they shed frequent bacilli and throat carriers. After that, the throat carriers. Transmission is through aerosol or sometimes through the contact, that causes cutaneous diphtheria. The reservoir of this disease is humans only. The common age affected is 1 to 5 years, and newborns are protected because of the maternal antibodies. The global situation, due to widespread immunization, cases are drastically declined by more than 95%. Currently, there are around 5,000 to 5,500 cases occur per year since 2005. But in India, it is highest burden, 60 to 70% of global diphtheria. 2016, there were 3,380 cases were there. The highest burden is from the Uttar Pradesh and Kerala and Karnataka. Maximum cases are of age 5 to 10 years. This may be because of the poor vaccination or the low immunity leading to adult diphtheria. The treatment, it is of two types. You have to start it immediately on the suspicion of diphtheria. The first is anti-diphtheric serum, that is antitoxin. It is a passive type of immunization, and in that it neutralizes the toxin. The trial dose is given to check the hypersensitivity reaction, and then in mild infection, that is early pharyngeal cases, it is 20,000 to 40,000 units, and moderate severe cases it is 40,000 to 60,000 units, and severe extensive and late cases, that is more than 3 days, it is 80,000 to 1 lakh units given. Antibiotics, penicillin or erythromycin is drug of choice. but antibiotics plays minor role in this disease treatment because it is toxin mediated, not the by bacteria. Antibiotics are useful if given less than 6 hours of infection before the toxin release. So it prevents the release of toxin by killing these bacilli, and it is treatment of cutaneous diphtheria, and in carriers erythromycin is the drug of choice. Now prophylaxis is because of the vaccination. So diphtheria toxoid is used in the as a vaccine. So there are three types of vaccines: the single vaccine, combined vaccine, and pentavalent. Single vaccine, it is diphtheria toxoid, alum or formal precipitated vaccine. Then combined vaccine, it is DPT, that is diphtheria pertussis, that is whole cell, and tetanus toxoid. DAPT, it is diphtheria, tetanus, and acellular pertussis. Then DT is diphtheria and tetanus. Small dt, it is tetanus and adult diphtheria toxoid. Pentavalent vaccine contains diphtheria, pertussis, tetanus, hepatitis B, and Haemophilus influenzae type B. So, some little detail about DPT vaccine. So the types of DPT vaccine are plain formal or adsorbed on alum. So schedule is given in 3 doses in the beginning, that is 6 week, 10 week, and 14 week of the birth, and then booster doses at 16 to 24 months, and then the second booster is at the 5 year, that is at the school entry. Then site is deep intramuscular at the anterolateral aspect of the thigh. The second method is passive prophylaxis, that is by using anti-diphtheric serum. So subcutaneously 500 to 1000 units are given. It is prepared from horse. Then combine first dose of adsorbed toxoid on one arm and second dose of the ADS, that is anti-diphtheric serum, on the other arm, and then followed by the complete active immunization. So this is combined time prophylaxis. In adult immunization, the DT vaccine is used, that is tetanus toxoid and adult diphtheria toxoid. So more than 18 years of the adult who have completely followed the primary vaccination schedule. So in that, booster dose once every 10 years is given till the age of 65. And who have not completed their primary vaccination schedule, in that 3 doses of DT is given: 0, 1 month, and 1 year. The adverse reactions following DPT can be mild or severe. So in mild, there can be fever and local reaction, that is swelling and induration. In severe type, whole cell killed vaccine of B pertussis is encephalotogenic. So it can cause neurological symptoms. Hence DPT is not recommended after 6 years of age. Absolute contraindication of the DPT is hypersensitivity to previous dose or progressive neurological disorder.
Hello students, today we will discuss about Clostridium perfringens. So in introduction, Clostridium perfringens are anaerobic gram-positive bacilli, boxcar or brick in shape, and they are spore-forming bacteria. And here you can see in this slide boxcar or brick appearance of the gram-positive bacilli. So pathogenicity of Clostridium perfringens. So first we will see virulence factors. So there are many factors, so like major toxins. So there are alpha, beta, epsilon, iota. These are major toxins, or minor toxins like gamma, delta, lambda, kappa, theta, or enterotoxin, which causes gastroenteritis or food poisoning, and others like enzymes like neuraminidase, histamine, bursting factor, etc. So these are all virulence factors to cause the pathogenicity of Clostridium perfringens. Then we will see clinical manifestations caused by the Clostridium perfringens. So Clostridial wound infection is, according to the MC Linen classification, they are divided into 3 types. So first is simple wound contamination, second is anaerobic cellulitis, and third is anaerobic myositis, or it is also called as gas gangrene. Now the other types are Clostridial enteric infection. So in that, food poisoning, necrotizing enterocolitis, gangrenous appendicitis is there, and in others like bacteremia, skin and soft tissue infection is there. So these are all pathogenic clinical manifestations of the Clostridium perfringens. Then we'll see now about gas gangrene. So what is gas gangrene? It is rapidly spreading edematous myonecrosis in crushed wounds contaminated with Clostridium perfringens. And here you can see in this photo, that is blackening of the some part of the foot of both legs. So that is gangrene. The gangrene pathogenesis. So first is anaerobic environment. In road traffic accidents, crushing injuries of muscles is there, and because of that interruption of blood supply is there, and then that causes tissue ischemia, and then it's contamination of wound with clostridial spores in soil, and because of that then you can see that infection of the Clostridial perfringens. Now, clinical manifestations of gas gangrene. So there can be sudden excruciating pain at site, rapid development of foul-smelling thin serous discharge, gas bubbles or crepitus in muscles, browny edema and induration. Now we will see laboratory diagnosis of gas gangrene. So first is a specimen collection. So in that, what samples we can collect? So it is exudate from the wound or necrotic tissue, muscle fragments. These are the specimens. In sample collection done immediately in Robertson-Cook media or thioglycolate broth to avoid exposure to oxygen. So whatever material we are collecting, that we have to put inside the Robertson-Cook media. So after sample collection, first we'll do microscopic examination. So that is by gram staining. So in that we can see gram-positive bacilli with boxcar appearance. Bacilli without spores is strongly suggestive of Clostridium perfringens. So in this slide you can see gram-positive bacilli, and they are boxcar or brick-shaped in appearance. Second step is inoculation done in blood agar plates, and plate is kept in gas pack system for anaerobic environment. Then we can see this target hemolysis in blood agar plates. So it is double zone of hemolysis. In this picture you can see double zone of hemolysis. So narrow zone of complete hemolysis due to theta toxin, and wider zone of incomplete hemolysis is due to alpha toxins. So this is target hemolysis seen in Clostridium perfringens in blood agar plate. Then we can do inoculation into the Robertson-Cook media, that is anaerobic culture media. So culture in Robertson-Cook media, so we can see saccharolytic property, that is conversion to the pink color of that meat particles. Now next step is Nagler reaction. So in that, in egg yolk agar plate, to 1/2 antitoxin is added and to 1/2 antitoxin is not added, and then streaking of the Clostridium perfringens colonies is done. So to the half where the antitoxin is not added, there you can see opalescence around the right streak, and to the half where antitoxin is added, so that antitoxin inhibits alpha toxin, and therefore you will not see that opalescence around the streak. So what is the principle? So here lecithinase, that is alpha toxin, has an action like phospholipase, and that hydrolyzes phospholipids present in egg yolk around the streak, and then you will see opalescence around the streaking of the colonies. Next is the biochemical reactions. So in that, stormy fermentation. So what is the procedure? In that, inoculate sample in litmus milk media and incubate. So you will see paraffin plug is pushed up and clots are seen in the test tube. So that is due to fermentation of lactose producing lactic acid and vigorous gas. So here in this diagram you can see one tube is having clots and stormy fermentation, and the another tube you will not see this clots and stormy fermentation. So this is used for the identification of Clostridium species, that is Clostridium perfringens. Now we will see gas gangrene prevention. So in that, this one sentence, care your feet as your face, or you will bury your feet before your face. So you have to take care of your feet. So that is clean any skin injury thoroughly. Watch for signs of infection such as redness, pain, drainage or swelling around the wound, and consult your healthcare provider promptly if this occurs. So you have to care for your feet before your face. Then we can see this gas gangrene treatment. So prompt surgical removal of dead, damaged and infected tissue, that is debridement, should be done along with clot and foreign material is necessary. The amputation of an arm or leg may be indicated to control the spread of infection. Antibiotics in combination with surgery effective. Drug of choice is metronidazole, that is given IV. Analgesics may be required to control pain. Hyperbaric oxygen may detoxify patients rapidly, hence been tried with varying degrees of success. Anti-gas gangrene serum can be required, and then food poisoning requires only symptomatic care.
Hope you find this session useful for your understanding and for your exams. Thank you.
Hello students, today we will have lecture on Clostridium tetani, Clostridium botulinum and Clostridium difficile. So introduction of Clostridium tetani, they are gram-positive bacilli with terminal round spores, and that gives drumstick appearance. In this diagram you can see gram-positive bacilli with terminal round spores, that is drumstick appearance. Normal habitat of the Clostridium tetani, they are present in soil, hospital environment, intestine of man and animals, and it causes tetanus. Tetanus, it is an acute disease manifested by skeletal muscle spasm and autonomic nervous system disturbance. Virulence factor of Clostridium tetani, so it is mainly toxins, and there are two types: hemolysin, that is tetanolysin, and neurotoxin, that is tetanospasmin. The situations where tetanus can be prevalent is surgical operations, punctured wounds, septic abortions, umbilical sepsis, unhygienic ear piercing or unhygienic circumcision. Now we'll see in little detail about toxins. So first is tetanolysin. So it is heat labile, oxygen labile. A property is hemolysin, and it is produced by Clostridium perfringens, Clostridium novae and streptopyogens. Then tetanospasmin, it is responsible mainly for the tetanus. It is heat labile, inactivated at 65 degrees Celsius in 5 minutes. It is good antigen and specifically neutralized by antitoxin. It can be toxided by using low concentration of the formaldehyde, and then that toxide can be used as a vaccine. Favorable disease conditions where you can see tetanus can occur, that is anaerobic environment, presence of necrotic material, then other bacteria infection, then lack of drainage, dose and toxicity of the strain is more important, then site and nature of wound, then immune status of the host, incubation for 6 to 12 days. Mortality rate 80 to 90% before specific treatment was available. Tetanus neonatal and uterine tetanus 70%, but now because of the all aseptic precautions and the vaccine available, the mortality rate or tetanus neonatal or uterine tetanus is reduced. Now we will see pathogenicity of the tetanus. So after the infection of Clostridium bacilli, that is Clostridium tetani, they are implanted in wound and then they form spore. They multiply because of the anaerobic environment present in the wound, and then they produce toxin, and this toxin is carried to the central nervous system via peripheral nerves. Then toxin fixed by gangliosides, and there is a block, and then because of that there is synaptic inhibition in the spinal cord. Tetanus is of two types, ascending tetanus and descending tetanus. So in ascending, it is up the spinal cord. So from the spinal cord to the opposing hind limbs, trunk and then forelimbs. And in descending tetanus, spasticity of head, neck and then the limbs involvement is there. Here in this picture you can see these photographs of neonatal tetanus. So it is simultaneous contraction of all the somatic muscles. Previously it was very common when vaccine was not developed because of the unhygienic delivery practice and application of the cow dung to the umbilical. So that favored the anaerobic environment, and because of that multiplication of bacteria, spore formation and then toxin, and because of that simultaneous contraction of the muscles. But now, because of the aseptic precautions taken while delivery, application of neomycin powder or antiseptic powder to the umbilical cord, and in ANC 2 doses of tetanus toxoid taken, and because of all these things, now neonatal tetanus rate is reduced. Here you can see in this picture tetanus in human. So it is simultaneous contraction of all the somatic muscles. Now after sample collection, first step is the direct microscopy, that is done by gram staining. So in gram staining of the material, you can see gram positive bacilli with terminal round spores, that is giving drumstick appearance. And in this diagram you can see drumstick appearance of the gram positive bacilli. Now after gram staining, you can do inoculation into the blood agar plate with polymyxin B, and then inoculation and incubation at 37 degrees Celsius anaerobically done. Plate is kept in gas pack system for 24 to 48 hours, and then after that in blood agar you can see swarming growth. So on blood agar, Clostridium tetani produces fine film growth, and then swarming is due to motility seen, and on fresh blood agar plate it is hemolytic, that is alpha hemolysis first followed by beta hemolysis. And in this plate you can see swarming growth of the Clostridium tetani. Inoculation done in Robertson cooked meat media, and then after a few days you can see proteolytic property, means meat is converted to black color with foul smelling. That is characteristic of the Clostridium tetani. Next step is the toxigenicity test, that is done for demonstration of the pathogenicity of the organism. So there are two types: in vitro hemolysis inhibition test, that is done for demonstration of the tetanolysin, and in vivo mouse inoculation test, that is done to demonstrate tetanospasmin. So in vitro hemolysis inhibition test, Clostridium tetani produces hemolysis, and then in one half of the plate if you add antitoxin, then that hemolysis is inhibited by adding antitoxin, that you can see in that plate. In vivo mouse inoculation, so growth of that material is injected into the root of the tail of the mouse, and then you can see ascending type of spasticity, that is from the hind limbs to trunk and then to the forelimbs you can see spasticity. In immunoprophylaxis of tetanus, DPT vaccine is given. DPT is diphtheria, pertussis and tetanus. So in the schedule of that is day 6 week, 10 week and then 14 weeks. And then first booster is given 16 to 24 months and second booster is given 5 years. In pregnancy, tetanus toxoid is given in 2 doses in 1 month interval, and in adult it is given 10 years and 16 years. Now we will see Clostridium botulinum that causes botulism. So it is a type of food poisoning. Botulism means botulum. So it is a sausage. It is saprophyte, these bacilli. They are mainly present in soil, vegetables, animal or hay. And the morphology is they are gram-positive, oval, bulging subterminal spores can be seen in gram-positive bacilli. Culture characteristics of Clostridium botulinum. So it is strict anaerobes, grow at 35 degrees Celsius. Colonies are large, irregular and semi-transparent, and spore production takes at 20 to 25 degrees Celsius. The classification of Clostridium botulinum into 8 types, that is A to H, and the toxin is powerful exotoxin, and that toxin inactivated at 100 degrees Celsius within 10 minutes. Toxin of Clostridium botulinum, it resists digestion, it blocks acetylcholine, and clinical manifestations of toxin can be seen as diplopia, dysphagia, paralysis and death. Pathogenicity of Clostridium botulinum is botulism, and there are 3 types mainly: foodborne botulism, wound and infantile botulism. So in foodborne, it is because of the contamination of meat products, canned vegetables, fish, that foodborne botulism can be seen. And in that symptoms are 12 to 36 hours of ingestion. You can see vomiting, thirst, constipation, difficulty in swallowing, speaking and breathing, and death because of the respiratory failure in 1 to 7 days. Infantile botulism can be seen because of the use of honey to the infants. And wound botulism, the toxin is produced at that site, it is absorbed, and then you can see wound botulism. Lab diagnosis of Clostridium botulinum. First is the specimen. So it can be food or feces. Then gram staining of that material is done. You can see gram positive bacilli with spores. Then that Clostridium botulinum can be isolated from the food and feces, and demonstration of toxin in food and feces can be done. Now we will see Clostridium difficile. So they cause antibiotic associated colitis. They are difficult to isolate. They are gram positive bacilli and spores are large, oval and subterminal. In pathogenesis of Clostridium difficile, they cause acute colitis with bloody diarrhea and pseudomembranous colitis. It is a common cause of nosocomial diarrhea. It follows the use of broad spectrum antibiotics, mainly clindamycin, to which organism is resistant. In lab diagnosis of the Clostridium difficile, the demonstration of toxin in feces can be done. The growth can be done in HEP2 and human diploid cell cultures, and demonstration of toxin in feces can be done by ELISA method. Treatment is metronidazole, that is drug of choice, and vancomycin and bacitracin can be useful.
Hope you find this session useful for your understanding and for your exams. Thank you.